Good morning, everyone. Myself, Dr. Satish Karandikar, Professor and Head, Department of Oral and Maxillofacial Surgery, Index Institute of Dental Sciences. Today, we will discuss on TMJ ankylosis. TMJ ankylosis or craniomandibular ankylosis. So, ankylosis means fused joint or stiff joint. Temporomandibular joint ankylosis or craniomandibular joint ankylosis in its true sense is characterized by formation of bony mass which replaces the normal joint architectures. The quality of life in such patient is greatly affected due to their deformed face and reduced jaw function, affecting speech, mastication, and deglutition. It is basically stiffening or immobility of joint or pathologically intracapsular fusion or union of disc condyle complex to temporoarticular surface. Because of immobility of joint, the jaw functions get affected. Hypomobility to immobility of the joint can lead to inability to open mouth from partial to complete. The incidence of intra-articular TMJ ankylosis is difficult to assess, but in Western literature, it is reported as decreasing due to better understanding of management of condylar fractures and also decreased incidence of middle ear infection following the introduction of antibiotics. But in India, the incidence of TMJ ankylosis is still high. The reported age distribution ranges from 2 to 63 years. Onset is usually seen before the age of 10. Etiology of TMJ ankylosis. The most common etiologies are trauma, infection, inflammation, systemic diseases, and other causes. Trauma due to forceps delivery, congenital trauma at birth, forceps delivery, hemarthrosis, condylar fractures, intracapsular, extracapsular, or glenoid fossa fractures, which are very rare. Infections such as infections due to conditions like otitis media, osteomyelitis of mandible, actinomycosis, abscess around the joint, furuncles, tonsillitis, parotitis. Inflammation leads to conditions like rheumatoid arthritis, osteoarthritis, ankylosing spondylitis, psoriatic arthritis, poliomyelitis. The rare causes in which TMJ ankylosis also seen are measles and polyarthritis. Systemic diseases which causes TMJ ankylosis are tuberculosis, gonorrhea, scarlet fever, typhoid, gonococcal arthritis, beriberi, etc. And miscellaneous it contains syndromes associated with TMJ ankylosis. Other causes also includes bifid condyle, prolonged trismus, prolonged immobilization, unknown causes and burns. Various hypotheses are proposed for temporomandibular joint ankylosis. The first is interfragmentary strain theory or parent strain theory, which tells that minimum strengths or limited movement of jaw will lead to endochondral ossification, causing bone formation, especially in areas of lateral part of joint following trauma. Bone formation following trauma is due to hemarthrosis Ferretti et al., which was given by Ferretti et al. Meng et al. Proposed that a force similar to destruction osteogenesis by the lateral pterygoid muscle during the sagittal condylar fractures, healing has a vital role in TMJ ankylosis formation. Hall's hypothesis proposed that genetic predisposition was responsible for TMJ ankylosis, but hypothesis proposed that postulated that hypercoagulability of blood could be contributing factors in traumatic temporomandibular joint ankylosis. All the above mentioned theories do not completely explain the development of TMJ ankylosis, with each one having its own flaws in completely elucidating the pathosis, with the condition being multifactorial in its initiation. The earlier or late hypothesis, including traumatic injury to pediatric condyle, explains that fracture of the pediatric condyle are more prone for development of ankylosis owing to peculiar anatomy of the condyle having a broad neck and highly vascularized head that has rich osteogenic potential when compared to an adult condyle. It is hypothesized that hemarthrosis, along with disruption of fibrocartilage integrity, allows the ingrowth of fibrous connective tissue into the joint, which later results in ossification. This figure shows in children of 2 to 5 years how TMJ ankylosis occurs. This is the thin cortex periosteum in active osteogenic phase. Here, hemarthrosis occurs, intracapsular comminuted fractures, perivascular bone hemarthrosis. Relatively broad condylar neck and thin articular surface. Trauma to the condyle in adults is most common at the neck of the mandible. Here it is shown in this figure. Neck of the condyle is most common fracture of the mandible in adults. In pediatrics, the condylar fracture is seen. It is mostly look like a mushroom-like pattern is seen near the condyle or mushroom-like deformity is seen. Classification of TMJ ankylosis. Kazanjian in 1938, it has given classification based on the type, which are false ankylosis or true ankylosis. It can be also classified as by side involved, unilateral or bilateral, according to the location which was given by Rowe in 1986. It is intra-auricular or extra-auricular TMJ ankylosis. Based on the type of tissue involved, which was also given by Rowe in 1986, it is fibrous or fibro-osseous or bony joint, bony ankylosis. Based on number of joints involved, it is unilateral or bilateral. Based on the extent or severity of the fusion, which was given by Rowe in 1986, it is complete or incomplete. Most cited Sony's classification based on the radiograph's findings, which is type 1, extensive fibrosis adhesion around the joint. Here you can see type 1 type of joint, type 1 joint according to radiograph. Extensive fibrous adhesion around the joint, condylar head is present without much distortion. Condylar head is present as it is without not much distortion. In type 2, bony fusion at the outer edges of the articular surface, but no fusion with the medial area of the joint. No involvement of sigmoid notch and coronoid process. In type 3, bony bridge between the mandible and the zygomatic arch is seen. Medially atrophic dislocated fragments of former condyle head can be found. Elongation of coronoid process is seen. In type 4, complete osseous block between ramus and skull base. Normal TMJ anatomy is completely disrupted. Now, clinical features of TMJ ankylosis. It is divided into two, unilateral and bilateral. Clinical manifestations vary according to severity of ankylosis, time and onset of ankylosis, and duration of ankylosis. Early joint involvement less than 15 years, severe facial deformity and loss of function is seen. Later joint involvement after the age of 15 years, facial deformity, marginal or knee, but functional loss severe. Those patients in whom the ankylosis develops after the full growth completion have no facial deformities. Facial asymmetry, it becomes progressively worse if ankylosis not treated early due to hypomobility and abnormal muscle function. The duration and more severe will be muscle atrophy and facial asymmetry will be seen. The short ramus condyle unit can be seen in severe cases of TMJ ankylosis. Also restricted mid-phase growth, secondary hypoplasia, and elongation of coronoid process can further restrict the jaw movements. In unilateral TMJ ankylosis, there is reduced or no mouth opening, obvious gross facial asymmetry with fullness on affected site and flattening on unaffected site can be seen. Occlusal canting can be evident. Shortening ramus height on ipsilateral or affected site. Prominent antigonial notch on ipsilateral or affected site. Class 2 Engels malocclusion with unilateral crossbite present in the affected site. Deviation of the mandible to the affected site. Elongated coronoid on the affected site or bilaterally. The chin is recessed with hypoplastic mandible on the affected side. Roundness and fullness of the face on the affected side. The lower border of the mandible on the affected side has concavity, which is antigonial notch can be prominent. Condylar movements are absent on the affected side. See, you can easily see the facial asymmetry, which is shown in this figure. Fullness on the affected site is seen and flattening on the unaffected sites is visible here. Due to the fused joint, there is no movement of the mandible unilaterally in this region. Reduced or no mouth opening due to the fusion of joint unilaterally or bilaterally. Occlusal canting is evident in this region as this area is ankylosed side. So occlusal canting and deviation of the mandible to the affected site is visible. It causes occlusal canting can also cause there is a unilateral crossbite is also seen due to occlusal canting. Shortened ramus height on the ipsilateral or affected site can be visible. Prominent antigonial notch on the ipsilateral or affected site can be visible. Elongation of coronoid process on the affected site or bilaterally is shown in temporomandibular joint ankylosis. Class 2 Engels malocclusion with unilateral crossbite present on the affected site. For bilateral TMJ ankylosis, the clinical features are reduced or no mouth opening, retrognathic, micrognathic, or burst bird face deformity due to inability to open the mouth, decrease in interincisal opening. The patient develops typically bird face deformity with receding chin, convex profile. No occlusal canting is seen in this type of joint in the bilateral temporomandibular joint ankylosis due to fusion of both side of temporomandibular joint. The neck chin angle may be reduced or almost completely absent. Shortened ramus height bilaterally. Antigonial notch is well defined, accentuated bilaterally. Class 2 Engels malocclusion may be present bilaterally. Upper incisors are often protrusive with Anterior open bite. Maxilla may be narrow. Proclination of lower anterior teeth may be seen. Oral opening will be less than 5 mm or many times there is nil oral opening. No palpable joint movements can be seen. Multiple carious teeth with bad periodontal health can be seen. Due to reduced mouth opening, the patient is reduced or none mouth opening. The patient can unable to clean his teeth. Severe malocclusion, crowding can be seen, and many impacted teeth may be found on X-rays. Also, elongated coronal process seen in the X-rays. Obstructive sleep apnea may be occur in the patients of temporomandibular joint ankylosis. As the ramus height is decreased, the patient is difficult to breathe. Diagnosis of temporomandibular joint can be done using orthopentamograph or cephalometric radiographs or lateral oblique view. Lateral oblique view will give anteroposterior dimensions of the condylar mass, elongation of coronary process. Cephalometric radiographs is used to check associated skeletal deformities. Orthopentamographs will help in joint picture which can be compared in unilateral cases. Presence of antigonial notch can be appreciated which develops secondary to contraction of depressor muscles and their action against elevator group of muscles. The antigonial notch becomes more pronounced in severe cases. It does not reveal the medial extent of bony mass and its relation to surrounding vital structures. Radiographic findings of fibrous ankylosis will show reduced joint space and hazy appearance can be seen, but still the normal anatomy of the head and glenoid fossa can be appreciated. In bony ankylosis, fusion of the joint with complete obliteration or loss of joint space can be seen. Normal TMJ anatomy is distorted. Deformed condylar head or complete bony consolidation replacing the joint space can be seen. Elongation of coronary process, hypoplasia on the site of the hypomobility will be seen. Now, management using fiber optic scope assisted intubation is useful while managing the TMJ ankylosis. As you see, the the right temporomandibular joint ankylosis revealing shift of the hyoid complex and the laryngeal inlet to the ankylosed site. This is hyoid bone. The laryngeal inlet is towards the hyoid site. The shift of genital tubercles to the ankylosed site with shortened suprahyoid musculatures on the same side. Mid-sagittal plane is shifted towards the affected side. Surgery of ankylosis may require staged procedure. One, release of ankylosis. Second, an orthognathic surgery or distraction to restore facial aesthetics and address OSA, especially in pediatric ankylosis with secondary deformity. Various incisions can be performed while managing TMJ ankylosis. While managing TMJ ankylosis, the most uh, anatomical structures to be preserved are facial nerve. The distance of the facial nerve from bony external auditory canal to the on the lateral surface of malar arch midway between its upper and lower border, where the most posterior significant tweak of temporal ramus of facial nerve crosses the arch. The distance is zero point 0.8 to 3.5 centimeters. The distance of external auditory canal to the bifurcation of main trunk of the facial nerve. Distance of external auditory canal to the bifurcation of the main trunk of facial nerve is almost 1.5 to 2.8 centimeter, and the distance of the distance from postglenoid postglenoid tubercle to the main trunk furcation of the facial nerve where it bifurcates is 2.4 to 3.5 centimeter. These are the anatomical landmarks to be preserved during incision of management of temporomandibular joint ankylosis. Surgical access or incisions for the management of TMJ ankylosis are Dingman incision, Blair inverted hockey stick incision, Thomas incision, Alcad Bramley incision, Popovich modification incision, endural approach, post-auricular approach, Rhytidectomy, retroauricular limb of rhytidectomy incision. Alcath and Bramley incision or Alcath and Bramley approach for temporomandibular joint ankylosis is most commonly used. This is reverse question mark shape, cosmetically acceptable incision, give ac- excellent access to the TMJ without causing any damage to important anatomical structures. It starts superiorly through the skull in the temporal region and extend to the inferior tragus. This incision begins about pinna length away from the ear antero-superiorly, just within the hairline and curves backward and downward, well posterior of the main branch of temporal vessels, till it meets the upper attachment of the ear. The incision then follows the attachment of the ear and just endurely. The temporal incision must be carried through skin and superficial fascia to the level of temporal fascia. In the temporal region, the incision should be extending from skin superficial fascia to the temporal fascia region. The temporal incision must be carried through skin, superficial fascia, and the level of temporal fascia. The nerve filaments runs in the superficial fascia, and it is very important that the full depth of this fascia is reflected with the skin flap. Blunt dissection in this plane is carried downward to a point about 2 centimeter above the malar arch where the temporal fascia splits. The pocket formed by the division contains fatty tissue which is easily visible through the thin layers. Beyond this point, there should be no attempt at further dissection of the superficial fascia from the temporal fascia. Starting at the root of malar arch, an incision running at 45-degree upward and forward is made through superficial layers of temporal fascia. Once inside this pocket, the periosteum of the malar arch can be safely incised and turn forward as one flap with the outer layer of temporal fascia, superficial fascia containing the nerve and skin. The pocket can be developed anteriorly as far as posterior border of frontal process of malar bone and posteriorly joined to preauricular dissection, which follows closely the cartilaginous external auditory canal beneath the glenoid lobe of parotid gland and the superficial temporal vessels. A small tortuous branch, the auricular artery, runs backward from the superficial temporal artery to the ear. The middle temporal artery, which comes off superficial temporal artery, perforates the temporal fascia to supply temporalis muscle. This should be divided and ligated, proceeding downward from the lower border of the arch and articular fossa. The tissue lateral to the joint capsule are dissected and retracted. The base of the neck of the condyle can be exposed. The bifurcation of the facial nerve is not nearer than 2.4 centimeter in an inferior posterior direction from the postglenoid tubercle. Care is needed not to extend deep dissection below the lower attachment of the ear. Repair of the layers presents no problem. The incised outer layer of the temporal fascia can be repaired entirely without tension. This is in marked contrast to the near impossibility of approximating the temporal fascia if it is incised at higher level, where it is a single layer of tissue. The minor modifications of preauricular approach have results in following advantage. There is minimal bleeding and less sensory loss. The posterior placement of skin incision and its wide backwards and upward sweep spares the main branch of vessels and nerves. Facial planes are easily identified. There is excellent visibility. This is partly due to large flap and partly because the unyielding temporal fascia is not reflected with the skin as in the approach described by Rose and King. The potential complication of muscle herniation and fibrosis are avoided. The muscle is never exposed and superficial layers of temporal fascia can be closed without tension. There is remarkably little post-operatively discomfort or swelling. A good cosmetic result is achieved except in the very bald. The technique is easily teachable and speedily executed. Smart procedure can also be performed for the management of TMJ ankylosis. In this, the bone is removed in the area of angle of the mandible so that proper movement of the jaw can take place. The angle shape, triangular shape at the angle of the mandible, the triangular shaped bone is cut so the proper movement of the mandible can be takes place. Surgical procedure to release TMJ ankylosis are condylectomy, gap arthroplasty, and interpositional arthroplasty. Condylectomy. Condylectomy is advocated in cases of fibrous ankylosis where the joint space is obliterated with deposition of fibrous band, but there is not much deformity of the condylar head. The condylectomy procedures can be carried out via preauricular incisions. This is a procedure where radiologically and clinically after surgical exposure, one can see the demarcation between the roof of glenoid fossa and the head of condyle. Horizontal osteotomy cut is carried out with the help of surgical burr at the level of condylar neck. Vital structures on medial surface of the condylar neck should be protected by using special condylar retractors inserted prior to bony cut. The condylar head, which is sectioned from the ramus, then should be separated from the superior fibrous attachment carefully and removed. The rest of the ramal stump should be smoothed out and wound closed in layers. Unilateral condylectomy tends to cause deviation of the mandible towards the operated side on oral opening, and if bilateral, anterior open bite will cause as a result of loss of height in vertical rami. Therefore, when the site of fused joint is mobilized via condylectomy, then after recontouring by arthroplasty and alloplastic material can be used to maintain the joint space, satisfactory occlusion and joint movements. Gap arthroplasty. It is also called as osteoarthrectomy